Hi, I'm Michael Killen of the Killen Report. The World Health Organization estimates that around 7 million people die each year from exposure to polluted air. Ambient air alone causes 4.2 million deaths, while household air pollution from cooking with polluting fuels and technology causes another estimated approximately 4 million deaths in the same period. Now, I have Dr. Paul Auerbach here, and he was a professor at Stanford Medical School, and he has some other credentials which I'll share. I'll get him to share possibly as we go forward. I'm interested in learning more about air pollution and its impact on human health. Now, how are you today?
I'm just fine. Thank you very much.
Okay, first of all, is that important what the World Health Organization says? 6, 7 million people die every year. That's around the world. Is that important?
I think it's important. Anytime we hear about deaths that are preventable, if we hear about suffering that's preventable, it's important to know the causes and to try and determine if something can be done to lessen that impact. So I would want to look more at those numbers and determine what the causes of death are beyond air pollution. So for instance, if we say that air pollution caused someone to die, it could have caused them to die because it either caused or exacerbated a pre-existing pulmonary disease like asthma or chronic obstructive pulmonary disease in smokers. It might have caused a death because someone had a heart attack and their cardiovascular disease was attributed in part or in whole to rugged environmental conditions like air pollution. So it's important to know what the cause of death was. And it's also important to know the age at which the person died. Could it be a bona fide premature death? Someone who dies at a very young age is probably more likely to have caused an adverse social outcome and disadvantaged a lot of people than someone who dies at age 95 from lung cancer because they've been smoking all their life and they got caught in a bad environmental condition. So I don't have any value judgment there. I'm just saying that there's still some devil in the details on this, but I think it's pretty well established that air pollution exists, that we know many of the forms of air pollution, and we also know what it would take to mitigate them, how to protect people. And if we know that that exists and we can make life better for people, we need to strongly consider that. So I would consider that a very important statement.
So you talked about the numbers for a while, and you're saying the numbers are okay, but you may have a patient who drops dead, has a heart attack. Other doctors might not be able, and that person that may have died because of air pollution aggravated a situation, but you're saying maybe the numbers might be much greater.
There's a chance that the numbers are much greater because we don't classify all morbidity and mortality through the lens of air pollution. If we did that, we would probably expand the numbers. We know that emergency department visits go up in times of bad air quality. And the visits are for disorders and diseases related to bad air quality. Now, some might be directly related, Some might be less directly related. So let's say directly related. If there's bad air quality and we see a surge in cases of asthma, which we always do, that's a direct cause and effect. If we see a hot summer where people can't get outside and may be uncomfortable, they may have more asthma, they may be suffering minor or moderate dehydration and symptoms of heat exhaustion. They might be depressed, emotionally depressed, and they may seek care for that. It might be harder to link that back to the environmental conditions that caused it, but they would have caused it nonetheless. So it takes a fair amount of intuition, sleuth work, diligence to always pin something on causation. And sometimes that's physical causation, sometimes it's the social determinants of health. Lots of things in the climate are interrelated, and we just haven't been in the practice of looking at healthcare and visits and general population health through the lens of our climate. Now, we're doing better now than we used to, but it's not a universal practice, and it really needs to be. You know, every patient that comes in with a cough or something wrong with their lungs gets asked, do you smoke? Did you ever smoke? And, you know, maybe we should be asking all these people, did you ever work in a coal mine? Did you ever live in Pittsburgh, Pennsylvania? Did you know, where were you last year during the heat of the summer when the wildfires were raging? That's the kind of inquisition we should be doing of our patients if we're going to start gathering decent statistics about what causes their problems.
I think you just made an excellent point. You know, I show up at the emergency room every now and then, again, smoking, alcohol, but they never ask where I might have worked before, what environment. And I think you, in making that statement, will educate some doctors and policymakers, health policymakers, to maybe promote that suggestion.
Yeah, I mean, it's more than just determining what that particular visit's about. It also plants a seed in the mind of the patient, because implicit in asking that question is that there's some kind of link. And you know, so it has them thinking about, you know, where was I during the wildfires? Were you inside? Were you outside? Did you hear warnings about air quality? Did you heed them? You know, it's a chance to do education all around.
Okay, can you give me 3 examples of something happening that creates air pollution? What are your favorites?
Yeah, I don't know if I'd use that word, but well, I've mentioned it a couple times already. Now, we have increasing wildfires and natural sources of smoke from burning wood and anything else that's burning in the vicinity of the wildfire. So that is something that we have to take into account, and that's very much linked to climate and warming and forest management, et cetera. Industrial air pollution leads the list. So manufacturers, refineries, any place that produces chemicals that gets emitted in smoke or anything similar to that, any particulate matter that gets released into the atmosphere, whether it can be seen with the naked eye or not, that's the major cause of the air pollution that's caused.
What about, forgive me for interrupting, what about electricity, utilities that are generating electricity using coal or gas?
Well, that would fall under the one that I just mentioned. So anything manufactured, utility plants, anything that has a byproduct of combustion, or one fuel being transformed into energy, at the expense of air quality, frankly. So, and then that air quality directly impacts humans. Methane is a special case. Methane is produced mostly by natural sources. Cows emit methane. There's a lot of methane stored in the permafrost, which, if that continues to melt, is going to release a lot of it, and that is 25 times as potent from a global warming impact as carbon dioxide, although there's much more carbon dioxide. So there are many, many sources of air pollution. The ones that we're focused on are the ones that are visible and right in front of us. So we see a lot of attention paid to automobiles,
Yes.
and nothing's perfect. So, as you just mentioned, electric cars consume fuel. There's fuel consumed to create the electricity. Some of them are hybrids and produce it directly. Nothing's perfect, so it's all a trade-off. So we're going to have to get to the point where we weigh the benefits against the hazards of every energy source that we use, because it's the energy sources that largely contribute to air pollution.
Okay, I'd like to jump to another topic. You're in the ER. All of a sudden, a mother comes in with a little child, maybe 5 years old. The kid looks like hell. And possibly they're having an upper respiratory problem. What do you think about? How do you approach determining what's the problem and what can you do about it?
Well, airways and catastrophic airway problems in any person is a cause for high concern and anxiety in providers, because in an emergency department, only a relatively small percentage of what we are called to deal with is actually a true emergency, and airways are at the top of the list. Because if an airway becomes occluded, you fundamentally, except in very special circumstances, have about 4 minutes before you have irreparable brain damage. That's the general rule in the absence of hypothermia. So that's an emergency, and you're trying to do multiple things at the same time. So hopefully, you control the chaos, get the room quiet, and while you're attending to any obvious remediable cause of the airway problem. So, for instance, the child may have a cold, but he also might have choked on a hunk of hot dog. Somebody may have a bad sore throat and have an infection in their uvula or their epiglottis that's obstructing their airway. There are a lot of different things that can cause shortness of breath and can cause a rapid demise in airway. Could be a diffuse lung problem. Somebody could have pneumonia or asthma and just not doing gas exchange very well. So you're trying really quickly to get some clues about what the problem might be, in hopes that you'll spot something that you can remedy really quickly. Somebody that's got 3 wasp stingers sticking out of their forehead and comes in wheezing and gasping for air, is probably having an allergic reaction. So you go in that direction. So that's what you're looking for. Meanwhile, somebody's trying to talk to anybody who can give you history, because you might just not see it. And somebody might say, oh yeah, this is my son. He has asthma. He does this every 6 months, and this is what we do. Or this is my son. He has cystic fibrosis. And when we have bad air quality and it's hot and he gets a little cold, he does this. So we're looking for clues for things that we can intervene on, and keeping our fingers crossed that if we make an intervention or interventions, they're successful. So there's a lot of activity. Meanwhile, you're looking around to see if you need backup for certain things and calling for help if you need it. If you anticipate that you're going to have what's called a difficult airway, you might be calling for a pediatric anesthesiologist to come down to help you in case a tube has to be passed. Because at this point, there's no pride involved. It's all about doing the right thing for the patient, getting the best people you can at the bedside to do that as fast as you can. So a lot of stuff going on. Clearly, when you get to be my age, you've been through this a few times, and I won't say completely automatic, but you're able to get things done quickly. Younger doctors need to be supervised, and that's why we have emergency medicine training programs so that they can get that experience and learn how to manage that kind of a situation.
Now, you said you have to be ready to call for help, and that's one of your principles that you live by when you work. You start to see there is a problem that you may not understand, or you think you might need help, you call for it right away. That's one of your principles of working.
Well, if I perceive that it's something that could go downhill in a hurry, I call for help right away, because I don't have the luxury of time to just kind of see how far I can get. It really depends on the acuity of the patient, how comfortable I am that I can manage the situation. But once I believe that there's a good chance I'm going to need help, I'd rather have a couple extra people in the room or standing outside, annoyed at me for calling them down when it turns out that I didn't really need them, than being in a situation where I really needed them and I didn't call for help.
Are there any other principles that you use in medicine to be effective?
We all have our techniques. I realize that patients come in, and only to a certain extent do they appreciate your technical expertise. They want to have somebody that knows what they're doing, and so it's important to be a good doctor, but it's more important to quickly connect with the patients and the family if you can, and to let them know that you're paying attention and that you're compassionate and you're going to be on top of everything, and establish a relationship of trust. That's the single most important thing you can have with patients, is a relationship of trust.
All right, I'm going to come back to trust, but first I'd like to finish this segment. You've worked with a lot of doctors in the emergency room, I think, or doctors in general at Stanford Medical. How many of them are tuned in to the threat of air pollution?
I can't give you a number. I would say that if you had asked me this a couple years ago, I would say that they would all have been familiar with air pollution and that it wasn't good, and that it caused disease, but they hadn't yet become activists or felt that it was important for them to be part of whatever effort it was going to take to change that situation, unless they just happen to be interested in environmental causes. I think now we're seeing a sea change as people are getting bombarded with information about climate change and the climate and the impact of climate change on human health. And so many more are concerned about it. And now what we're starting to see is that they're incorporating that into their thought processes, as we mentioned previously, and they're taking it up as a cause.
Good.
And that's so important. Medical students are eager to learn as much about this as they possibly can, and they should, because this
Wonderful.
is what they're facing. And they're more, this is an issue of great social concern for them. Whereas when I was in medical school 50 years ago, it wasn't the big cause. Environmental stuff was whales and polar bears, and now it's people, and that's different.
All right. At the beginning, we focused on the impact of air pollution, and you're convinced climate change is coming. And we now have a lot of different kinds of health issues. Like the wind is going to harm people, sea level, floods. Would you share what you think is going to happen in terms of the new impacts on human health as a result of maturing climate change?
Well, if the predictions are correct, and I'm not a climate scientist, so you and I are reading the same stuff and forming our own opinions. I think sea level rise is going to hit us sooner than later. And because I think it's one of those threshold phenomena where once we get, we breach the seawall, it's breached. And you can't catch up to that stuff. We've proven time and time again. Cleaning up after a flood is 10,000 times less efficient and effective than preventing the flood in the first place. So if sea level rise continues at the pace that it's predicted to, we're going to lose our coastal areas and large portions of them. And that's going to cause mass internal migration in the United States. And we're not prepared for that. That will bring with it many of the health impacts that we're seeing in some of the quote unquote third world countries, because we don't have a healthcare infrastructure that's doing all that well as we're witnessing right now with what we've got. And so I think sea level rise might come in first. Air pollution is just going to be an inexorable worsening until such time as we have a total reconfiguring of our economic incentives to burn fossil fuels. So I think that's going to be second. Global warming's is already here, and we're past the point of no return for a certain amount of temperature rise. And we've outraced our resources to deal with climate change related disasters. We don't have enough first responders. So if we keep having the forest fires we have and all the other related disasters, we're going to be in a bit of a jam. Is it inevitable? Yeah, part of it probably is inevitable, but I don't know which part. I wouldn't be buying coastal property in Florida right now. I just see that one coming at us a lot quicker. And, a lot of my friends live in these areas. And when I talk about this, they kind of look at me like, come on, Paul. And I go, well, it's just like you asking me a question. That's what I think,
Do you have this thought in mind when COVID-19 dies away, then sometime down the road, when climate change hits with much, much more force than COVID-19?
Well, I think they're independent of each other. People are trying to lump them, and what that's doing is it's diffusing and weakening the efforts that we have against climate change, because all of a sudden we've just shifted to COVID. And so people who were really quite active and preparing to deal with climate change are, I mean, I get it. You know, if I get this infectious disease, I, you know, could get wiped out. But it's let some of the steam out. And I think we need to get back to climate change because regardless of what COVID does, the climate change, unless we change the things that are causing it, it's just going to keep worsening and worsening and worsening, right? So, you know, the planetary patient has two diseases. They're different. They're not, unless someone can tell me that the spread of this virus or the emergence of this virus is related to some climate factor, it's a different deal.
Yeah, I was only relating it in terms of time. That's all. There's one disaster hitting us sometime in the future. We get hit with climate change.
Well, we're already hit with climate change. So we're ignoring the disaster that has already hit us to a certain extent in favor of going after one that looks like it might be worse in a shorter time period. Now, I'm not faulting anybody for that emotional reaction, but if we pull resources away from the efforts to understand climate change and to mitigate it and to deal with all the problems it's causing and will cause, then we will be doing, we might be doing mankind a big disservice.
Okay.